Hey, future doctors, thanks for tuning into Spoonful of Sugar, a podcast made for medical students by medical students to help the medicine go down. My name is Zoe Peltz. I'm a fourth-year student at Touro University, California, and I will be your host today. Today, we are going to be talking about eating disorders and related disorders. Throughout the podcast, I will be asking a lot of questions and will pause for a moment so that you can think about the answers and try to say them aloud. Feel free to pause the podcast as well if you need more time. And remember, this is just a review, so don't get disheartened if you don't know or can't remember something. The first disorder that we are going to be talking about is anorexia nervosa. This disorder most commonly affects young women, and it is defined by an intense fear of weight gain and body image distortion, leading to calorie restriction and severe weight loss way below normal BMI. Typically, in test questions, you'll see a BMI below 18.5. There are two subtypes of anorexia nervosa. The first is the binge eating / purging type, which involves reoccurring purging behaviors. These can involve laxative or diuretic abuse or self-induced vomiting or binge eating that lasts over 3 months. What electrolyte abnormality can be associated with this subtype? Hypokalemia, from the vomiting and or diarrhea. The second subtype is the restricting type. This is disordered behaviors including dieting, fasting, and or overeating. You can differentiate this from the binge eating / purging type because it does not involve purging or binging behaviors. Some physical exam findings in someone with anorexia are things like bradycardia, hypotension, and cold intolerance. What's another pretty classic skin finding common between patients with anorexia and babies? Lanugo. This is basically fine, downy baby hair that grows due to malnutrition. Some other complications of anorexia include myocardial atrophy, arrhythmias, dry skin, gastroparesis, constipation, and in severe cases, seizures. Now let's talk a little bit about the pathophysiology of anorexia. So severe calorie restriction leads to a starvation state, which then leads to some endocrine changes. Can you think of which are the main hormones that get decreased in anorexia? Leptin, GnRH, LH, and FSH. And what can this lead to? Hypothalamic amenorrhea, which is why these patients can stop menstruating. Chronic malnutrition can also lead to bone loss, which results in osteopenia or osteoporosis. One very important concept to understand for anorexia is refeeding syndrome. So when someone who is severely malnourished begins eating again, insulin secretion increases and shifts the electrolytes phosphate, potassium, and magnesium into cells. The most characteristic of these findings is in anorexia nervosa is serum hypophosphatemia. Hypophosphatemia can cause cardiac failure, respiratory failure, rhabdo, and neurologic symptoms such as seizures. Thus, refeeding must be done gradually and carefully. Treatment for anorexia nervosa includes nutritional rehabilitation, psychotherapy, especially CBT, and olanzapine can work too. But in general, medication is unfortunately less effective in anorexia, whereas psychotherapy works the best. Our next topic will be bulimia nervosa. This is reoccurring episodes of binge eating with compensatory purging behaviors at least weekly over the last 3 months. BMI is often normal or slightly overweight. This is often the best way to differentiate between the binging, eating / purging type of anorexia versus bulimia. Some compensatory behaviors include vomiting, laxatives, diuretics, and excessive exercise. Some associated physical exam findings include parotid gland hypertrophy, which is associated with increased serum amylase, enamel erosion, Mallory-Weiss syndrome, and in severe cases, Boerhaave syndrome, aka esophageal rupture. What is the main difference between Boerhaave's and Mallory-Weiss syndrome? So Mallory-Weiss is just superficial tears, whereas Boerhaave's is full thickness tears causing esophageal perforation. Dorsal hand calluses from induced vomiting is also an associated physical exam finding in bulimia. And what are these called? Russell sign. As spoken a bit about in the purge subtype of anorexia, vomiting in bulimia can cause electrolytes abnormalities. Particularly, vomiting causes loss of gastric acid, which produces metabolic alkalosis, classically with hypokalemia and hypocholemia, which can lead to dangerous complications such as cardiac arrhythmias. Treatment for bulimia includes psychotherapy, nutritional rehabilitation, and SSRIs such as fluoxetine. What drug is contraindicated in bulimia treatment? Bupropion, due to the seizure risk. So these last disorders I'll go into a little less detail because they're less high yield, but they're still good to know regardless. So another disorder is binge eating disorder, which involves reoccurring binge eating episodes, but without compensatory behaviors. Because of no purging, patients are usually overweight or obese, and for diagnosis, it must occur at least once per week for 3 months. The last 3 eating disorders are a little bit different than the above disorders. The first is pica. These are episodes of eating non-food substances not recognized as normal, and it has to be at least or over 1 month. Non-food substances such as ice, plaster, chalk, and hair. People sometimes do it to provide emotional relief, and it is commonly seen in children and during pregnancy. What elemental deficiency is associated with pica? Iron deficiency, specifically iron deficiency anemia. Other issues associated with it are malnutrition, developmental disabilities, and emotional trauma. And the treatment, first line is psychotherapy and nutritional rehabilitation, and second line is SSRIs. The next sort of different eating disorder is ARFID, also known as avoidant restrictive food intake disorder. It is characterized by inadequate food intake, but importantly, without the body image concerns that we see in disorders like anorexia nervosa. Patients with ARFID may avoid food for a few different reasons. Some have strong sensory aversions to certain textures, smells, or tastes. Some have fear of choking, vomiting, or have had other negative experiences with eating, and some just have low interest in food altogether. It is especially common in children, and it is also frequently seen in individuals with autism spectrum disorder. Some clinical consequences include weight loss, nutritional deficiencies, dependence on supplements or tube feeding, and impairment in social functioning like difficulty eating in group settings. Treatment focuses on behavioral therapy, nutritional rehabilitation, and addressing any underlying anxiety or sensory sensitivities. The last eating disorder we are going to talk about is rumination disorder. This involves the repeated regurgitation of food after eating. What's distinct about the regurgitation in this disorder is that it is effortless. This distinguishes it from other disorders such as bulimia or GERD. Unlike vomiting or reflux, regurgitation is typically autonomic, non-acidic, and may involve rechewing or reswallowing. It is not associated with nausea, retching, or gastrointestinal illness. It occurs in both children and adults and is sometimes seen in individuals with developmental disorders, but it can also occur in otherwise healthy individuals. Unlike bulimia, this behavior is not driven by concern about weight or shape, which is an important distinction. Treatment often involves behavioral techniques, especially diaphragmatic breathing, which can help interrupt the regurgitation reflex. So thank you guys all for listening. If you found this episode helpful, please subscribe to our podcast. If you have any questions, comments, concerns, please visit our website at spoonfulofsugar.org and post them under the link for this episode. Good luck with studying, and remember that if you ever have an SOS moment while studying, Spoonful of Sugar is always there to help the medicine go down.